This is Chapter 30, Assessment of the Cardiovascular System. These are your concepts. Of course, the priority concept for this chapter is going to be perfusion, because that's what our cardiovascular system does. Also, an interrelated concept is fluid and electrolyte balance. Now, the assessment of the cardiovascular system is going to involve evaluating the adequacy of the heart's ability to pump blood and to get it out there to perfuse the tissues. So the perfusion process is similar to a plumbing system. The heart acts as the pump to deliver oxygenated blood to the cells, and the vascular network functions as the pipes. The heart has huge metabolic requirements. It extracts approximately 70 to 80% of the oxygen that is delivered to the other organs. 80%. It's huge consumption. So where are the coronary arteries? The left and right coronary arteries and their branches supply that blood, that 80% of the blood to the heart. These arteries originate from the aorta, and that's just above the aortic valve, the leaflets there, and it's they get perfused during diastole. So think about it. It's not when the heart is pumping the blood, but during diastole. An increase in the heart rate will shorten that diastole, and it can decrease myocardial perfusion. The heart consists of three layers. The endocardium, which is the inner layer, that lines the inside of the heart and the valves. The myocardium is the muscle. That's the muscle fibers, and it's responsible for pumping. The epicardium is the exterior layer of the heart, the outside of the heart. Now, you need to be aware that the heart is encased in a thin fibrous sac called the pericardium, and that's composed of two layers. Adhering to the epicardium is the visceral pericardium. This is also enveloped in the parietal pericardium, and that's a tough tissue that attaches to the great vessels, the diaphragm, the sternum, and the vertebral column, and that's what supports the heart in your chest. The space between those two layers is called the pericardial space, and this is filled with about 30 milliliters of fluid, and what that does is lubricate the surface of the heart and reduces friction during systole. So that's a down and dirty assessment of your cardiovascular system in the heart. So let's look at the inside of the heart. It's a hollow muscular organ. It's located at the center of the thorax, and it occupies the space between the lungs and rests on the diaphragm. It weighs about 300 grams, although the heart weight and size are absolutely influenced by age, gender, body weight, and how much physical exercise and conditioning a person does. And of course, it is affected by heart disease. So a normal resting adult heart beats 60 to 80 times per minute. That's a resting heart rate. Each ventricle will eject approximately 70 milliliters of blood per beat and has an output of approximately 5 liters per minute. The heart has four chambers, and it's divided into two sides, the left and the right, by a muscular partition which is called a septum. These sides are subdivided into an upper chamber, which is the atrium, and the lower chamber, which is the ventricle. Now, you need to know most of this slide. You just need to understand it, okay? The blood flow sequence. The unoxygenated blood, which I have in blue here, it goes from the systemic circulation, that's the rest of the body, systemic, and it travels to the right atrium via the superior vena cava and the inferior vena cava. So you've got a superior and an inferior vena cava. The blood will flow from the right atrium through the tricuspid valve and into the right ventricle. The right ventricle. From the right ventricle, the blood flows through the pulmonic valve, and that's where it goes into the pulmonary circulation, or the lungs, via the pulmonary trunk and the arteries. Okay, so that's your unoxygenated blood, still unoxygenated at this point. But from there, when it gets into the pulmonary trunk and the arteries, it becomes oxygenated. So the blood becomes oxygenated as it passes through the pulmonary circulation and into the lungs. The oxygenated blood will flow through the pulmonary veins into the left atrium. And then the blood will flow from the left atrium, the top, through the mitral valve, down into the left ventricle. And then that oxygenated blood will fly through the left ventricle, through the aortic valve, and go to the rest of the body via the aorta and all of its branches. That's a good slide to know. So let's remember, there are four chambers of the heart: the right atrium, the left ventricle, the left atrium, and the left ventricle. The right atrium pumps the blood to the right ventricle. The right ventricle pumps the blood to the lungs by the way of the pulmonary artery, which then pumps blood to the left atrium and then to the left ventricle and then out through the aorta. So we know that. Well, let's talk about how it gets there. You got heart valves. There are two types of valves: the atrioventricular, which is the tricuspid and the mitral, and the semilunar, which is your aortic and pulmonic. The functions of the valves are: the AV valves, that's your atrioventricular valves, prevent backflow of blood from the ventricle to the atrium during systole. The semilunar valves prevent backflow from the aorta and the pulmonary artery to the ventricle during diastole. All valves close and open passively by pressure gradient. The valves of the heart secure a one-way blood flow through the heart and the blood vessels for transmitting the blood. The heart separates the pulmonary and systemic circulations, which ensures that the flow of oxygenated blood to the tissues. So that's what it does. This ensures that flow of blood, oxygenated blood, to the tissues, not backing it up. Okay? Now let's talk about the mean arterial pressure, the MAP. And you have to have an MAP between 60 and 70 millimeters of mercury to maintain adequate perfusion. You must have an MAP between 60 and 70 millimeters of mercury to maintain adequate perfusion. This is important. Your MAP is determined by the cardiac output. The systemic vascular resistance, otherwise known as SVR, and central venous pressure, according to the following relationship. And this is based upon the relationship between the flow, pressure, and resistance. That is your mean arterial pressure. This mean arterial pressure is defined as the average pressure in a patient's arteries during one cardiac cycle, one heartbeat. It is the average pressure in a patient's arteries during one cardiac cycle. Another way to calculate the MAP is to first calculate the pulse pressure, which is done by subtracting the diastolic blood pressure from the systolic blood pressure. Then you divide that by 3 and then add the diastolic blood pressure. So here's your equation. MAP equals 1/3 of the systolic blood pressure minus the diastolic blood pressure, then plus the DBP, the diastolic blood pressure. You will be asked to calculate one of these, or to answer a question related to it that you would need to know how to calculate it. So learn this, please. Thank you. So let's talk about the cardiac cycle. It's a series of pressure changes that take place within the heart as it beats. That's what it is. These changes result in the movement of blood through different chambers of the heart and the body as a whole. These pressure changes originate as conductive electrochemical changes within the myocardium that result in the concentric contraction of the cardiac muscle. The valves within the heart direct that blood movement, which leads to organized movement or propulsion of blood to the next chamber. This rhythmic sequence causes changes in the pressure and volume that are then seen graphically in the form of venous pressure tracings. That's how we see this on a cardiograph. This cardiac cycle has two main phases. We know that, don't we? Systole and diastole. And this is defined by whether the heart is depolarized and contracting versus repolarized and relaxed. So, some more math, sort of, kind of. Cardiac output is the amount of blood that's ejected from the left ventricle into the aorta of your heart and then out to the rest of the body in 1 minute. That is what cardiac output is. And how that's written is heart rate plus stroke volume equals cardiac output for 1 minute. So while the heart rate is an undisputed contributor to cardiac output, the faster it is, the harder it is to push out. Stroke volume is the other major player. As heart rates vary to changes in cardiac output demand, then the stroke volume will also vary. The stroke volume is the amount of blood ejected from each beat that fluctuates with changes in the preload, afterload, and the catecholamine release. Now, that's a pretty big statement right there, and we'll go into it a little bit more, but that's what stroke volume is. It's the amount of blood ejected with each beat, which fluctuates with changes in what's coming in, what's going out, and the hormones that are, or the catecholamines that are released. So, how is this applied in the clinical setting? Well, think about it. A client with cardiac failure or congestive heart failure has increased pressure being backed up from the rest of the body because of high blood pressure. So, more volume, high blood pressure. So, the left ventricle struggles to pump out blood to relieve the pressure inside the heart. For this reason, stroke volume would be decreased because that left ventricle is unable to pump efficiently. So stroke volume would be decreased because it's not pumping. So this will back up the traffic of too much blood, which is causing that left ventricle to swell or inflate because it is trying very hard to push blood out. But it's going against the resistance of that high blood pressure. The amount of blood is pushing against. There's too much volume. So, you have a decreased stroke volume and a decreased cardiac output, which is going to make that left ventricle get bigger. And that's called ventricular hypertrophy. So, this is what happens when somebody has too much blood, too much volume, which causes a high blood pressure so that the heart can't push against that. It's got to go somewhere when it pushes out against it. I hope you understand that. So, when the cardiac output is not meeting the required amount of blood in a minute, the stroke volume is having a hard time getting pressure off from the heart because of that resistance. That's where preload and afterload come in. Preload is the stretching of the ventricles. The ventricles tend to stretch and fill with blood and then squeeze that blood out. If there's too much pressure filling the ventricles, they tend to extend to the point that they don't push it out. That's your preload. Afterload is just a fancy word for the pressure required for the left ventricle to force blood out of the body or out of the heart. Remember, in cases of congestive heart failure or hypertension, you have a backup of pressure on the left ventricle, which causes it to stretch at great lengths like a rubber band, causing a bigger preload and a struggling afterload. So your preload is that stretching of the ventricle. People who have acute MI, acute myocardial infarction, are given nitroglycerin and morphine to help bring down that preload and afterload, because nitroglycerin will relax smooth muscle to allow vasodilation, and morphine is a central nervous opioid analgesic that relaxes the heart. So, understanding preload and afterload is pretty important. Remember, preload is the stretching of the ventricles. The more stretch, the less proper contraction you're going to get. And afterload is the degree of the pressure inside the aorta where you're pushing that blood out. So it's just sitting there, and there's a lot of pressure to push against because you're full. The body's full. So afterload is just the effort of the ventricle to squeeze. So let's look at the vascular system. What are we pushing against out here? The whole vascular system. Well, the blood circulatory system delivers nutrients and oxygen to all cells in the body. It consists of the heart and the blood vessels running throughout the body. The arteries carry blood away from the heart. The veins carry it back to the heart. The system of blood vessels resembles a tree. The trunk is the main artery, which is the aorta, and it branches into large arteries which lead to smaller and smaller vessels. The very smallest arteries end in a network of tiny vessels, which we call the capillary network. There are two blood circulatory systems in the human body which are connected. The systemic circulation provides organs, tissues, and cells with blood so that they get oxygen and vital substances. The pulmonary circulation is where the fresh oxygen that we breathe in enters the blood. At the same time, remember, carbon dioxide is released from that blood. So, this is a very simple slide here. The purpose of the arterial system is to deliver at the tissue level nutrients, chemicals, and body defense substances and exchange that for cellular waste products depending on the needs of that particular tissue. The arteries transport the cellular wastes to the excretory organs, the kidneys and lungs, to be reprocessed or removed. This also helps regulate the temperature in our tissues. Now let's talk about the blood pressure regulation. This involves quite a bit of help. You know the heart supplies the organs and the tissues of the body with blood, and with every beat it pumps into the large vessels of the circulatory system. And as that blood moves around through the body, it puts pressure on the walls of the vessels. So blood pressure readings are made up of two halves. And I know, or two values, and I know y'all know this, but this is a review, okay? The systolic blood pressure is the pressure when the heart beats. While the heart muscle is contracting, it's squeezing and pumping oxygen-rich blood into the vessels. That is systole. Diastolic blood pressure is the pressure on the blood vessels when the heart muscle relaxes. The diastolic pressure is always lower than the systolic pressure. The kidneys are going to provide a hormonal mechanism for the regulation of blood pressure by managing blood volume and other things. There are the kidneys also help regulate blood pressure by monitoring the sodium, and we'll talk about that, or you'll learn more about that in the when we talk about renal. But this is very much the renin aldosterone mechanism that regulates blood pressure by managing the blood volume. Changes in blood pressure are routinely made in order to direct amounts of oxygen and nutrients to specific parts of the body. So when you exercise, you need more oxygen to the skeletal muscles, so the blood delivery to those muscles increases, while blood delivery to the digestive organs would decrease. So adjustments are made when forces are applied to your body, such as when starting or stopping in an elevator. Okay, your baroreceptors are sensory neurons that monitor arterial blood pressure. The major baroreceptors are located in the carotid sinus. That's an area of the carotid artery just above the separation from the aorta. You also have your aortic arch and the right atrium. Chemoreceptors are sensory neurons that monitor the levels of CO2 and O2. These neurons let the cardiovascular center um, know when levels of oxygen or CO2 drop or the CO2 rises, which results in a drop in the pH. These chemoreceptors are also found in the carotid bodies and the aortic bodies located near the carotid sinus and the aortic arch. So you've got those baroreceptors and your chemoreceptors. The veins return blood to the heart from all the organs of the body. So the primary function of the venous system is to complete that circulation. The large veins parallel the large arteries, and they often share the same name, but the pathways of the venous system are more difficult to trace than those of the arteries. So many of the changes that relate to aging within the cardiovascular system are a result of a loss of cardiac reserve. And that will become apparent when a person is physically or emotionally stressed and the heart just cannot meet those increased metabolic demands of the body as they age. And all of that is related to the valves, the conduction system, the ventricle, the aorta and the large arteries, and the baroreceptors. These change, and they do okay as long as they're not emotionally or physically stressed. Okay, these are cues that you would want to recognize. You have a lot of modifiable and non-modifiable risk factors. Obviously, those modifiable risk factors would include the smoking, physical inactivity, diet, obesity. Psychological factors would include um, any stress related or illnesses, medical history. You would want to know what their risk factors for coronary artery disease, and those risk factors are high LDL cholesterol, low HDL cholesterol, high blood pressure, family history, which you can't change, diabetes, which you can control, smoking, which you can change, and being postmenopausal for women, which you can't change, older than 45 for men. So, um, if they've had previous treatment for coronary vascular disease, that would be part of their history. You would want to know about their drug history, what medicines are they on, and also the social history, what their lifestyle is, and their nutrition. Diet plays a huge part and is modifiable. Family history and genetic risk. A lot of families do have a history of heart disease, and that is something that you cannot change, but you can be aware of and change other things to compensate for that. Of course, current health problems. What do you have wrong with you now? COPD or high blood pressure. Those are obviously things you want to know and recognize as cues. The traditional risk factors we've talked about. Also, let's talk about functional history. This is classified by 1, 2, 3, and 4 by the American Heart Association, and there is um, a table in your book that if you're interested in looking at that, it will help you to understand which stage a person might be in um, related to the functional history. So this is related to the degree by which ordinary physical activities are affected by heart disease. Can they walk? How far can they walk? So all of these are the functional history, and they are classified by the American Heart Association. So, um, psychosocial assessment. Too many people, the heart is a symbol of their ability to survive, exist, and love. You have to assess the meaning of the illness to the patient and family and what they perceive as their stressor, and then assess their coping behaviors related to the anxiety and the denial of having anything wrong with them. Now, we need to look at their labs, and this is really an important part of knowing where you are with cardiac disease, especially if they're having pain or if they have a tendency to develop heart disease. Now, some of your cardiac lab values are the troponin complex. This will peak in 10 to 24 hours and will start to fall off after 1 to 2 weeks. Troponin T is a protein that's found in the blood and is related to the contraction of the heart muscle. Troponin T is very, very valuable in detecting heart muscle damage and risk. So you have troponin 1, and the value is less than zero point 0.0 to 0.10. Troponin T is also less than zero point 0.0 to 0.10. So it's important that you know those values. Okay, total cholesterol. This is the amount of blood your body's um, of your blood's cholesterol content. This is the amount of your blood's cholesterol content. A high level increases the risk of heart disease. So ideally, the total cholesterol should be less than 200 milligrams per deciliter or 5.2 millimoles per liter. We see it as the 200 milligrams per deciliter on our lab values. High density protein, lipoprotein, is the HDL. This is called the good cholesterol because it helps carry away the LDL, which is also known as the bad cholesterol, keeping the arteries open and the blood flowing more freely. Low density lipoprotein is not good. It's called the bad cholesterol. Too much LDL cholesterol in the blood causes plaque. That's what causes the plaque to build up in the arteries, and that will reduce blood flow. So these plaque deposits sometimes will rupture and cause a blood clot or a platelets to rush there and start trying to fix that rupture, and it can cause major heart and blood pressure problems. If you're a man, your HDL cholesterol levels should be over 40. Now that's your good cholesterol. And women should have HDL over 50. Ain't fair, is it? Okay. Triglycerides. The triglycerides are another type of fat in the body. The high triglyceride levels usually means you eat more calories than you burn. So high levels can increase the risk of heart disease. the triglyceride level should be less than 150 milligrams per DL. So your LDL cholesterol should be less than 130, and desirable levels are under 100, especially if you have diabetes or a history of heart attack, a heart stent, heart bypass surgery, or other heart or cardiovascular systems. The recommended, in that case, the recommended LDL is below 70. So there are a lot of other diagnostic assessments. They would look at the PA and lateral of the chest x-ray, because they're going to look at the size of the heart. They can do angiography. They can go in there and look at the vessels. They can look at the cardiac catheterization. They can look at the vessels of the actual uh, cardiac arteries, and of course the EKG, conduction studies, exercise electrocardiography, echocardiography, the TEE, which is a transesophageal echocardiography, which they can go in there and look to see if there's any blood clots or vegetation on the valves. Of course, they can do the nuclear perfusion imaging now, and the CT or an MRI. These procedures, such as the cardiac cath, the angiography, electrophysiology studies, and the nuclear cardiology, what it does is it allows the doctors to diagnose heart and blood vessels conditions with greater precision and accuracy. This offers the patient a greater potential for a rapid, uncomplicated recovery from some diseases, such as having vessels that are occluded, so they can go in there and look. So these are all diagnostic procedures that you may see, especially if you're working with cardiac patients. So let's look at one of these. This is cardiac catheterization. This involves threading a long tube or a catheter into the arteries to bring those tiny miniature cameras and instruments to where they can see the heart vessels and see a disease site in the heart or the blood vessels. So what it does is it portrays a kind of an image of the vessels. It is used to evaluate chest pain, identify narrowed or blocked arteries, and they can also do angioplasty and restore blood flow to threatened heart tissues without surgery. And they can reopen a blocked artery. And sometimes they can do that using a keep it open with a small, it's kind of a mesh collar, and it's called a stent. Okay, let's look at our diagnostic assessments that we talked about earlier, just a little bit more in depth. The EKG, of course, shows the electrical activity of the heart and can show abnormal rhythms or dysrhythmias. This can sometimes, and it can also detect heart muscle damage. EPS is the electrophysiology studies that they can look at to map the electrical activity of the heart. And that takes quite a while sometimes, and they will sometimes use ablation to alter the electrical activity of the heart. Stress test is treadmill or exercise EKG. This is done to monitor the heart when you stress it or walk on a treadmill or pedal a stationary bike. And they monitor your breathing and your blood pressure, and it can be used to detect coronary artery disease. and also to determine safe levels of exercise after a person's had a heart attack or heart surgery. They can also use drugs to stress the heart if they're not able to do physical activity. The transesophageal TEE is a test that is done with medicine to you give sedation. It's invasive because they put a like a probe, like EGD, like they were putting a probe down into your body or in the esophagus, and so they swallow that little probe. It's about the size of your thumb, and you have to swallow it, and it goes down into the esophagus, and that lies directly behind the heart. So it lets you see a really close look of the heart structure and the function real time. And it is you can look at the heart valve structure and the function of those heart valves to see if there's any regurg or any leaflet problems. And they can also see if they have any blood clots or if they have atrial fib or any dysrhythmias that can cause blood clots. They can see if there's any blood clots in the heart. The MPI is non-invasive imaging test that shows how well blood flows through the heart muscle. So this is it's fairly new. Okay, so here's some questions. If you want to look at these, you may go ahead and look at them. I have the answers here. I'm not going to read through these. You can do these. It is a good thing to do to help you remember what we've talked about. Okay? Now, that ends chapter 30.